Hello, and welcome to the AASM COVID-19 Health Policy and Legislative Update. I'm Deirdre Gray, the ASM Director of Health Policy, and I will be the host for today's session. I'm also joined by our Advocacy Program Manager, Eric Albrecht. I'd like to review a few logistical items before we get started. First, please note that since the information from the government is rapidly evolving, information provided on this webinar is up to date as of Monday, April 27th. Also, this webinar will be recorded and will be accessible online in the AASM store. A link to the webinar and a copy of the slides will be sent to all participants within the next day or two. Lastly, if you have questions throughout the presentation, please submit them through the chat feature, as we will review questions during the Q&A session after the presentation. If we are unable to address your question during the time allotted, we will follow up with you offline. And with that, I'd like to introduce today's presenter. David Introcaso, PhD, began his career in Washington, D.C. General Hospital in the mid-1990s. Since then, he has worked at NIH, the Agency for Healthcare Research and Quality, as agency's evaluation officer, a public health analyst in the Office of the Assistant Secretary of Planning and Evaluation. He's also served as health policy advisor to House Majority Leader Representative Steny Hoyer of Maryland, and has numerous years of experience working as a consultant for the American Heart Association, the American Public Health Association, the National Hospice and Palliative Care Organization, and for United Health Group, among many others. He has also taught as an adjunct professor at the University of Chicago and the George Washington University. And he also had a 3-year W.K. Kellogg Foundation National Leadership Fellowship from 1993 to 1996. He earned his undergraduate and graduate degrees at Rutgers and Arizona State, respectively. So without further ado, I will turn it over to Dr. David Introcaso.
Thank you, Deidre. Good morning to everyone on the call. And certainly I hope this call finds everyone well. So thank you for joining us. So what I'm going to try to do in the next 30 minutes is get through approximately 20 slides. I will emphasize or reemphasize Deidre's comment that this information changes daily, if not hourly. And let me make note of 2 documents which I believe were forwarded to you in advance, which I highly recommend you review if you haven't already. And we update these documents again at least daily. So first document is Strategic Healthcare's document. It's a 20-plus page document in table form where we identify legislation and regulatory waivers and guidance relative to policy reforms at the federal level concerning the pandemic. And then let me make note of as well, and I do applaud AASM staff in preparing a review of CMS's interim final rule that appeared in the Federal Register April 6th. And that was well scrubbed again by Eric, Deidre, and staff at ASM, providing an explanation of details in it. So I recommend you keep those 2 documents close hold because again, this is changing daily. So just a few quick comments on background here before we get into the details. So as everyone knows, we've been hard hit by the virus. We're a 3rd in world infections and now up to a 4th in world deaths. So it's hit the United States hard. There have been 4 congressional laws passed to date concerning the pandemic. And just let me make note of there's an expected 4th that's now being debated. If it passes, it would be sometime in May. You probably read there's already concern about, from the Republicans, starting Mitch McConnell, about the extent to which this is going to add or contribute to the federal deficit. So passing this 4th supplemental will be difficult. The Democrats would like to provide funds for state and local governments. The recent estimate is state governments are probably looking at, by 2022, $500 billion shortfall. And the Democrats would like to see monies as well for frontline first responders here as it relates to treating these patients, provide them some financial relief, and actually there's some discussion about some whistleblower relief in there, or at least help them retain their jobs if they make comments about PPE. So the monies out to date, one might argue, have not been spent in the best manner. Just to note quickly, front page of the New York Times yesterday had a discussion about the $350 billion that went out in loans under patient payroll protection, and how those monies were allocated. And then I'll get to the $30 billion that was allocated a couple of weeks ago under, and how that went out related to the $100 billion under the CARES Act. So with that, let's get started. So you see the title slide right now, ASM COVID Health Policy and Legislative Update. Okay. So as I noted, there have been to date 4 legislative bills passed and signed. These are the dates, these are the titles, and these are the dollar amounts. Obviously, the largest is the March 27th. This is the CARES acronymed Act at approximately $2.2 trillion. And then the most substantive of all the documents, CMS and others, so SAMHSA, HRSA, FDA, CDC, and others have put out related to the PHE, is this interim final rule. This is the title. You can find it under this title in the Federal Register, and appeared in the Federal Register on this date, April 6th. So that's just an overview. Let's go to the next slide. And what I'm going to do in this presentation is spend a fair amount of time on telehealth, because this is probably the issue most relevant or of most interest to you. So the next 6 odd slides concern the telehealth provisions, because again, I do think these are probably most relevant. Just to say, if you don't know, telehealth coverage began under Medicare in '97, and it was strictly limited. To give you an idea, annual claim reimbursements under Medicare for telehealth were approximately $20 million, and that's over a $600+ billion denominator. So telehealth was really restricted, now not so much with the PHE. So the first bill of the 4 I noted in the previous slide does this, grants a waiver authority for these 3 federal programs. The CARES Act did a lot more for telehealth. And was there a question? Okay, I'll just keep going. So the CARES Act does a lot more relative to waiving previous telehealth restrictions. So you'll see these bulleted here. I'll not read through all these because I have 30 minutes. I want to get through these, so you can read what these are. But fundamentally, it gets rid of the originating site and the rule provision, which is what is done. Moreover, here you'll see there's some provisions as it relates to FQHCs and RHCs. And then for certain diagnoses, home dialysis visits, hospice research can be done via telehealth. They used to have to be face-to-face. Here's some more details relative to Medicare waivers for telehealth delivery. It started retrospectively March 6th for the PHEs, the public health emergency duration. It includes E&M visits, which of course are widely billed. Preventive mental health, there are actually 80 new ways in which care can be delivered under telehealth. Those are all specified in the interim final. And you could read through these others. It allows for HIPAA non-compliant technologies like FaceTime. You can use audio only for certain E&M codes. It waives cross-state licensure requirements for using of telehealth. This is a massive change in telehealth policy. And of course, the reason or rationale is pretty obvious. the feds wanted to appropriately make sure that timely access could be maintained during the pandemic. And you'll see waives all originating site and role restrictions, which I noted. That's the sixth bullet down. And this is the language specific to continuous positive airway pressure. I was encouraged to put this in the deck, and this is quote unquote the waiver as it relates. So you could read this as finalizing on an interim basis will not enforce the clinical indicators for coverage across respiratory, allowing for maximum flexibility for practitioners. This is really what these waivers are all about. Policy includes a CPAP for sleep apnea. Medicare will cover CPAP devices based on the clinician's assessment of the patient. However, once the PHE is over, we'll return to the enforcement of clinical indicators for coverage. So this gives you an idea. The next couple of slides are just some data that I pulled from various resources relative to utilization. And this data is a week old. You'll see this was drawn April 17th, last week. This is interesting, just the circle on the right. Share of PCPs using at least some telehealth, 97%. Frontline providers using 57%. In fact, I'll just cite these right now. I have talked with some folks. So, for example, Intermountain Health in Utah used to do 100 telehealth visits a week. Now they're doing 10,000. Okay, that gives you an idea of what has resulted from these waivers. So I'll just leave it at that. I do have some other, I have some data on Stanford, UCSF data as well, but I think Intermountain gives you an idea. So telehealth utilization, again, per frontline provider and primary care provider, time spent on telehealth by activity. For each frontline and primary care, you can see how that time is being spent, and you can review that. So let's just keep moving here along. Additional Medicare waivers for telehealth. So just some added detail. This allows providers home as a distance site without enrollment. Allow patients home is an eligible originating site. Those two are substantial changes compared to how it used to be delivered previously. Supervision has been relaxed per the last comment. So again, just some additional details there. So this table, as I mentioned, I said 80, 85 new telehealth billing codes, including critical care, home visits, speech therapy, etc. You can read through this, the various attributes in the far left column, and then some details relative to how these work. You'll see in the second through fourth column, and you can review those at your leisure. Just a couple more, 3 slides, I believe, 3 or 4 slides here. Selected services newly allotted during the public health emergency as it relates. So this is some CPT codes on some specifics. Again, you can read through those at your leisure. Next slide. So this is RPM, remote patient monitoring. In fact, I was on a call last week, and there's going to be an absolute boom in the marketing and advertising of peripherals and RPM, because the expectation is these waivers will be made permanent. I'll get into that later. So RPM, not just for the homebound, and some codes here, some weedy detail there, and then I think just 2 more for telehealth. So this is coverage by payer. Now keep in mind, this is outdated as of last week. This is changing regularly. So there are 48 Blues plans. If you look at the next to last line. So of the 48 Blues plans, this is the number as of last week that are doing these activities noted in the 5 columns. And then you see CMS, United Healthcare, major plans, Cigna, and Humana. And then Medicare Advantage, I'll note, is question mark, because just as a generic, you should probably already know, but may not. CMS, because CMS cannot demand or dictate how Medicare Advantage plans contract with providers. So they can say, CMS could say in guidance, we encourage or we allow, but they can't direct because they have a by law a non-interference clause. They can't tell a private commercial Medicare Advantage plan or an MAO how it should contract with its providers, other than to say it needs to provide all the care or the same amount, or the same care as Medicare fee-for-service. So they have to provide all the care fee-for-service provides, but they cannot tell them exactly how to do it, and certainly contract specifics which are proprietary to MA plans. Let's go to slide 13, and this is Medicare Advantage. And here are the details relative to MA as it relates to telehealth. Again, it's unclear to what extent, unless, of course, the Medicare Advantage plan makes known publicly how they're doing this. And I will say, if you're interested in MA, AHIP in the last couple of days came out with a lengthy, detailed memo of by plan. I think it actually is in alphabetical order, A through Z, what their member plans are doing in response to the COVID-19 pandemic. So there's details in there, just generic, but since those plans also run MA, probably applies to their MA contracts as well. So if you want to get into that. And let's go to slide 14. So now we're off at telehealth, and let's try to get through the remaining 8 slides or so here. So because there's been much discussion about this $100 billion under the CARES Act, I was asked to provide some details about this. Bottom line is, to date, $50 billion. Now remember, this is grant money. This does not need to be paid back. So there's $100 billion in grants available, and this is per the legislation. "Quote unquote," eligible healthcare providers in these 3 payment areas. I will tell you overall, this was drafted in very vague legislative language, and that's caused a lot of blowback. You're probably aware. The monies are for, in the second line, and this is right out of the bill, building temporary structures, leasing properties, etc., and that to be eligible, a provider, and this is quote unquote out of the legislative language, shall submit to the Secretary an application. That's not been the case to date. The initial $30 billion went out without any application. And then 60 days, Secretary should report to Congress on obligated funds. So regarding the initial $30 billion tranche of money that went out about 2 weeks ago, just to say there's been a lot of blowback, because if you look at how the money was divvied out by state, Kentucky received $311,000 per COVID-19 case. New York received $11,800. So mass, great variation. And I selected those states because I'm sure you can realize Kentucky's the home of the Senate Majority Leader, New York's the home of the Senate Minority Leader. So you could certainly infer this is money's being allocated in a political manner. Last Wednesday, HHS announced allocating another 20 of the $100 billion. And now here are the details. $10 billion would go allocated, excuse the typo there, for a targeted distribution to hospitals in areas that have been particularly impacted. So hopefully New York would see more in New Jersey. $10 billion for rural health clinics, and $400 million to the Indian Health Service. Let's go to slide 15. Here, as the title related, CARES Act grants to providers. I did want to highlight this and give details here. So when I mean to providers, these, let's just go through this. So per this press release, and note the last, providers can register for the program. So there's, again, as announced in early April, a portion of $100 billion of the Provider Relief Fund would be used to reimburse healthcare providers, et cetera. Every healthcare provider who's provided treatment for an uninsured on or after February 4th can request claims reimbursement. Okay, so if your TIN, for example, tax ID number under which you practice, you can submit a reimbursement claim. Steps will involve, you'll see here, enrolling as a provider participant, checking patient eligibility. Providers can register for the program on April 27th, so as of yesterday, and begin submitting claims in early 2020. For more information, go to this website. So some of this $100 billion is going to reimburse providers. This, of course, means physician practice offices for treatment for uninsured COVID patients on or after February 4th. So those are the details there, and there are two websites there you can go to. So that is slide 15. Let's go now. The next few slides, we're just going to quickly run through a number of bulleted items, and there are 3 slides. You see, this is Roman numeral 1. So let me just start with the let's just go to the second bullet. This is because this is generated a good deal of conversation. This is the accelerated advance payments. So per CARES, up to 100% of last 6 months of payments. So last 6 months, basically they said the last 6 months was through last December. You could get 100% of your last 6 months of Medicare reimbursement forwarded to you as a loan, as an advance payment. It's guesstimated about $100 billion has gone out to providers under this advance payment. Now, this advance payment existed before, had been in existence before the pandemic. It's just they tweaked it to allow, opened it up to pretty much anyone and everyone. The terms are which, of course, beginning in month 4, you repay at this pretty high interest rate per law. CMS says they can't change that interest rate. And the way you repay, just for the detail, is you're not actually writing a check. Beginning in month 4, CMS starts to claw back some of your loan money by not reimbursing some of that claims money beginning in month 4. So that's how the repayment is made. The repayment's passive from your side or end. Monday or yesterday, CMS noted it was quote unquote reevaluating, and this morning CMS said it was suspending the program, and they cited the fact that in the 4th supplemental that passed late last week, there's another $75 billion that has caused CMS to say we're going to shut down this accelerated advance payment expansion. You probably know sequestration was temporarily lifted. This is the 2% for this period, 5/1 to 12/31. There's an increase in hospital payments, and then there are any number of grants. You'll see here HRSA, SAMHSA, FCC. There's a payroll tax delay, and then the $75 billion I just referenced. That's the first bullet. That's the last or the 4th supplemental that was passed last week. So that's the $75 billion in addition to the $100 billion. And it says here additional monies for providers to be distributed using CARES language. So they're using the same vague language they used in the CARES legislation to distribute the $100 billion as they are in distributing this additional $75 billion. You might think they would have learned a lesson, but not the case. Again, any number of additional top of line, or I'd like to think more noteworthy waivers. So you probably heard this was the quote unquote hospital without walls waiver, the idea being that hospitals could care for positive treatments and ideally impetus to segregate them, hotels, dorms, and then they broadened the transfer rules and ambulance authorities, ED screening via drive-through, lab tests at home, frontline staff waivers, so includes cross-state line care, and you can read these. There is guidance on elective surgeries. Most recently, last week, they updated guidance, typo there, sorry, to restart based on whether state region passed gating criteria. And now, so it looks like many states aren't abiding by gating criteria. Ambulatory, it should be ASCs, again, sorry, enrolling as hospitals. The split ventilator waiver, which got for co-venting, there was guidance, wasn't so much a waiver as guidance that the Surgeon General put out. It's a fascinating document clinically if you want to read it. It's 52 pages, I believe, quite interesting. The interoperability rule, final rule that CMS came out with recently, that was delayed. Again, sequestration, as I noted. And then FMAP, this is the federal Medicaid share. Families First, which was the first of the four, temporary increased 6.2% effective 1/1 through the last quarter of the last day of the last public health emergency quarter. So this is the third. So are there any number of post-acute waivers? The 3-day SNF rule, which means you couldn't be admitted under Medicare to SNF unless you were in the hospital 3 days prior. That's waived. There's an IRF, inpatient rehab facility, long-term care hospital waiver, and just a generic long-term care waiver relative to transferring patients. There is EMTALA guidance regarding how hospitals can change their required EMTALA mandate for screening, testing, telehealth. There are changes in MACRA. This is the 2015 MACRA rule that created MIPS and the APMs. CMS relaxed or suspended surveys and audits, not surprising. And then these are the 1135 rather, Medicaid waivers. And as of yesterday, CMS has approved over 125 of these requests for states to modify their Medicaid programs in any number of ways. Here are insurance-specific changes. Let's start with the ACA marketplaces. You may know that almost all state-run marketplaces created an open enrollment period because as people lost insurance or were laid off because of the pandemic, they could enroll in a marketplace plan. Medicare, there are no out-of-pocket costs relative to COVID, and coverage also includes inpatient stays for quarantining, script refills, more than 30 days, etc. Medicare Advantage, again, I use the word allows because CMS can't dictate or mandate, so allows plans to waive out-of-pocket, and prior authorization gets waived relative to COVID-19. Medicaid, the first supplemental requires plans to pay for testing, including lab fees, et cetera. And private plans require testing coverage. I was asked to provide a fair amount of detail on Stark. This is physician, this is otherwise more formally physician self-referral law. Pete Stark obviously was known as the author. Actually recently passed away. So CMS issued 18 waivers from Stark sanctions, all related to all related blank waivers must be solely related to COVID-19. This is in the interim final rule. You can find the details thereof. Defined in part as diagnosed or medically necessary treatment code for any patient or individual, whether or not the patient is diagnosed with a confirmed case. So you could read through that relative to as Stark would apply. And here are some examples. The first few here, you're probably well aware, these were widely reported in the media. The hospitals can provide meals, comfort items for their providers, and childcare. And then there's some dollar details, probably too weedy for the slide. But if you read the interim final, it gets into this level of detail. If you go down to the fifth line, providers can pay above fair market value to rent equipment or receive services. Providers can support each other financially. Physician-owned hospitals can increase the number of licensed beds, OR, and procedure rooms, furnish medically necessary care in a patient's home. and provide imaging at alternative locations. So that's just some of the examples. So there's a lot of stark detail, and this gives you a flavor for it. We just have one more slide here. Select other reforms. Somewhat redundant, HR allows an interim hospital to provide larger child care services. And then there's flexibility as relates to written versus verbal orders. Patient consent. This is the 42 CFR Part 2 matter, and that the CARES Act allows broader sharing of substance use disorder patient records, SUDS records, under the public health emergency, which were limited, again, under federal law, limited liability for volunteers, and the Defense Production Act has been evoked on a few occasions to allow the Secretary to work with manufacturers on PPE. So that's somewhat of a whirlwind in a half hour. The next slide just says, Deidre, as you'll show, 22 questions and discussion. Again, I encourage you to look at our table that we update. In fact, the table that I know Eric sent out was probably as of yesterday morning, but we just updated it this morning. In fact, when you get to the updates, it actually provides the date and the time. Things are moving rather quickly. So we update that, and every update we make, we forward to AASM. They have always the most current table update of what's going on. And then I would also encourage you, obviously, there are any number of CMS web pages. In fact, if you go to the CMS.gov homepage, there's obviously an immediate link there to what CMS is doing. And if you really want to get into, there are other communications that CMS puts out for various distribution lists. I would not rely solely, here's my warning, don't go to the CMS newsroom because a lot of this stuff doesn't show up there. You think it would, but it doesn't. I've learned my lesson the hard way. So Deidre, that's it. I'm happy to go back to, you can bring up any slide of the 20-odd if there's a question related to, but if we could try to, I will say this on questions, I'll give it my best shot, but there's just so much material. If we're unable, and I'm unable to answer the question, we'd be happy to research it, certainly for my own learning curve, and get back to you. So Deidre, I'll turn it back over to you.
Thank you, David. So as David said, we're going to spend some time responding to the questions that have been submitted through the chat feature. Okay, so the first question we received covered now, based upon clinicians' determination, it may be withdrawn once COVID-19 waivers are no longer in effect. So
I'll make a run at that, Deidre.
Sure, I was just going to clarify that I think this is in reference to when you were saying, when you were explaining that in the interim final rule, that CMS said that that they could use the clinician's assessment in order to be able to give like CPAP and things like that. So they're asking if the patient will have to return the CPAP machine after the waiver is no longer in effect.
That's not how, I don't interpret it that way. I interpreted this as, now let's assume, and there's wide speculation, I'll just say as a generic here, there's wide speculation to the extent to which these waivers will persist, because the view is that the pandemic will demonstrate, we hope will demonstrate to us a way to deliver care more readily, with less regulatory rules and barriers. And of course, this administration, certainly more than previous, has been very supportive. You know, they've had this initiative for now a year or two called Patients Over Paperwork, which is they're all about cutting so-called red tape. So there is discussion that these waivers may persist beyond the point when the public health emergency is declared over. Let's assume that's not the case. Let's assume CMS says public health emergency is over and these waivers on a certain date expire. if the physician has already prescribed equipment and CMS has reimbursed it, there would be no logic or reason for the patient to return it. I think what happened is if the waiver sunsets and we go back to the pre-waiver regulatory control, all that means is that going forward, say like beginning May 1, the physician will no longer be allowed to, in some ways, this some ways interpreted as a Stark violation, and so will no longer be able to provide the equipment directly to their patient. Feel free to add to that, Deidre.
Yeah, I interpret it as that once the public health emergency has ended, that you'll have to return to following the recommendations and requirements in the local coverage determinations. But for questions, specific questions like that, or if you want to get details or perhaps get that in writing, which would, I think, be a good thing to do, you should reach out to your Medicare administrative contractor. All of the MACs have been holding their own webinars and really sending out a lot of information to try and educate the providers in their area. And if you need the contact information for your MAC, it is available on the ASM website, or feel free to send an email to coding@aasm.org and we can get you the contact information for your Medicare administrative contractor.
Yeah, I'd very much second that, because it has been the case in the past, and Eric and I discussed this yesterday, where one MAC interprets CMS policy in one way and another MAC interprets it as another way. So it really comes down to, on occasion, the interpretation by your specific MAC.
Okay, next question. If we reopen our sleep studies prior to CMS rescinding the interim rules, will we be able to perform a sleep study if the office notes are older than 6 months, but were less than 6 months prior to the temporary sleep center disclosure? Or sorry, prior to the temporary sleep center closure?
Deidre, I'm going to at least ask you to start with an answer on that one.
So I'm going to try and interpret the question. So let me just repeat it. If we reopen our sleep centers, I think, prior to CMS rescinding the interim rules, we'll be able to perform a sleep study if the office notes are older than 6 months. So I'm assuming that you're saying you've seen the patient over 6 months ago for the in-person evaluation, the comprehensive sleep evaluation, but now you want to perform the sleep study based on that. I think that as long as the whatever you're doing is consistent with what's included in your local coverage determination, it'll be fine. But the problem is there's the disclaimer within the interim final rule that states that once the public health emergency is over, everything goes back to normal. So if it's past the date and the public health emergency has been declared over and everything is back to normal, everything in your local coverage determination will be in effect. So you'll have to follow whatever is in that. If there is a time limitation in your local coverage determination, then you won't be able to perform the sleep study. You'll have to see the patient again, but it depends on what's in your LCD. So again, I would encourage everyone to check your LCD or to follow up with your Medicare administrative contractor with regards to that. Do you have anything to add to that?
No, it would be smart of me not to say more.
Okay. Okay. So the next question, we need information on how to protect sleep lab technicians and patients when we open up the lab again, what PPE or protocols to follow.
Well, I think, quickly, do you want to go with that? Go ahead.
Yeah, I was just going to say one thing and then you can have it back. I know that we have a webpage on the ASM website called COVID-19 Mitigation Strategies for Sleep Clinics and Sleep Centers, specifically focused on reopening. And the information was updated as of yesterday. So that would be a really good resource to check out. But if you have more to add, David, please go ahead.
No, I was just saying, I'm sure you cite this on your webpage, and that is, there's all sorts of CDC guidance on this.
Okay. How many military hospital ships did Kentucky get? And how many ventilators did the federal government send to Kentucky?
Good question. Well, Kentucky's landlocked, so I guess it's hard to get a ship there. I can't, that's a good question on the ventilators. I suspect this question is being generated by the amount of money they got from the first tranche of the $30 billion. I don't know. In fact, I don't know if that's actually even relative to ventilators. That may be knowable anecdotally from just media coverage, but I don't know if anyone's keeping some sort of master list. I will say, as you know, the federal government is not taking responsibility for supplying states with PPE and equipment. And this has been a sore point in an argument certainly between Governor Cuomo and the president. And in fact, if you look at, for example, front page, the in-house editorial today in the New York Times got on this subject. I will say it's more than likely, certainly, the distribution hasn't been equitable. And as you know, states compete with one another on equipment, which is causing, of course, price inflation. Or some of this is actually being done in very odd manner. You may know that New England Journal of Medicine published a piece a week ago by a Massachusetts physician who, in a stealth-like manner, knew a guy who knew a guy who knew some PPE equipment could be had, and they drive down. He doesn't even mention in the essay what state. He goes, a mid-Atlantic state, and they meet in a parking lot, and the trucks are labeled like fresh produce or something. I mean, it's just the FBI stops them at one point. I mean, it's really unbelievable, but that's what we're down to. Probably saw Maryland Governor Hogan secured some South Korean PPE because he took the initiative. So it's just really a mess. And I appreciate the question, but I think the only thing worth saying again is it's either unknown, inequitable, and likely on balance inadequate.
Thanks, David. Next question, can you elaborate more on the $75 billion that was approved?
Right, so I'm glad you asked. So this is the second. So again, it was the $100 billion in CARES, and then per my noting, this is the April 24th Paycheck Protection Program and Healthcare Enhancement Act. So that $484 billion, most of that, of course, for the title went to additional funds for paycheck protection. About $75 billion is to go to providers atop the $100 billion. How that gets distributed is unknown because, again, the language in last week's bill relative to $75 billion is the same language relative to the $100 billion in the CARES Act. I will say, relative to the Paycheck Protection Program here, and I'm looking at my notes. Of the $484 billion, other than the $75 billion that vaguely goes to providers who have to try to backfill for unpaid COVID patients, $600 million is to go to health centers, $225 million for testing at rural health centers, $1 billion is going to test covered tests for the uninsured, and then $11 billion to states and local entities for testing and scaling up labs. So those are additional related monies under last week's legislation, in addition to the $75 billion. But again, how that $75 billion gets allocated is again as vague as how the $100 billion is getting allocated.
Okay. Next question. Is there any fast tracking of CMS provider credentialing, reassignment, or adding of locations?
Well, on the latter, adding locations, de facto, yes, in that CMS has allowed, as I noted, under the Hospitals Without Walls provision, for hospitals to provide care in alternative settings. So you could say de facto that's fast-tracked. On the credentialing, I would assume so. I would have to look into the specifics and candidly, off the top of I don't remember reading anything per se about credentialing. So I'd have to look into that, unless, Deidre, you know otherwise.
No, the only thing I noted in the final rule, in the interim final rule, was that they were allowing for residents to be able to bill for treating patients during a public health emergency. But outside of that, I'm not aware of anything else.
No, good point. Both that, expanded abilities for residents, and then, of course, they loosened supervision requirements in overseeing both residents and then mid-levels generally.
Right. Okay, so then is telehealth only restricted to May 31st at normal reimbursement, and can it be extended?
Well, again, I'm not clear about the May 31st date, but I did note in the slides that telehealth is expanded. I'd have to double back here relative to, but it's through the public health emergency, and it's being reimbursed at the office. Generally, the telehealth reimbursement is the same as during the PHE as office visit reimbursement.
Correct. We are in a tri-state area. Is it okay to do video visits across state lines?
That's yes, because CMS did waive or allow for cross-state practice. Did waive or allow for physicians to practice cross-state.
Has there been discussion about sleep providers being able to also dispense sleep DME equipment to CMS patients without regulatory issues?
Well, Deidre, did we not discuss that, and was not that the topic of slide 5?
Yeah, so just to summarize, CMS did relax the requirements for the LCDs, the local coverage determinations, and said that, you know, DME equipment, including CPAP, can be dispensed based on the clinician's assessment of the patient during the public health emergency. But once the public health emergency is over, everything goes back to normal. Okay, so yeah, a lot of questions about prescribing CPAP without a sleep study. And yes, again, that's allowed during the public health emergency. Can a provider do a video visit from home and bill Medicare?
Yeah, a provider can do a telehealth visit from their home. Yeah. So it could be home to home. So there's no originating site for the patient. So both the provider and the patient can be in their respective homes.
And there's going to be more information on the ASM website. We have a summary of the interim final rule that spells out all of the things most relevant to sleep medicine. This is one of the things that is there. They talk about the originating site and a lot of information that's helpful for telehealth if you weren't using it before.
And just to reemphasize or repeat on slide 4, relative to telehealth, you could bill back, if you had it, you can bill or amend. So relative to telehealth waivers and application, they were made retroactive to March 6th, and the waiver will persist for the PHC duration.
Okay. CMS is now looking at the amount of loss by a provider when compared to 2019 numbers, but will they take into consideration any PPP money a provider may have obtained when figuring out if the CMS money needs to be repaid?
So this, if you're talking repayment, you're talking about the advanced or accelerated payment. So again, the accelerated payment is based on 6 months previous claim, Medicare claims, and CMS, those 6 months are July to December of 19. And so you get that money forwarded to you. Again, you have to begin repaying, or CMS starts clawing it back the 4th month after 4 months. But there's no factoring or calculating PPE to mind. So, for example, I think the question suggests, so say I got $1 million, and beginning month 4, they start clawing it back. My understanding is it's not clawed back less the money the provider spent on PPE. That's my understanding. Now, it does make sense. You would think they would accommodate for that. But I've never seen that anywhere, so I'm reasonably confident that's not the case. I will say this, and I hope this is helpful. I should have made note of it. As it relates to the advanced payments, there is a concerted effort by hospitals and other organizations, I should say, and Strategic Healthcare has been at the forefront of this as advertisement, to have the Congress pass legislation excusing the advanced payment clawback. So the view is that providers have incurred more than this $175 billion or substantially more to their loss to their business, and therefore the advanced payment monies should be forgiven, meaning not repaid. At minimum, the Congress should revisit that 10.25 interest rate. But the ask is that the repayment be forgiven. And if you think about a couple things, one, the pandemic persisting in intensity, or there being a second peak come 4 months from now, and no additional monies beyond the $175 billion being allocated in grants, it becomes very difficult for the Congress, particularly 10.25, to start clawing back that money, particularly in light of really any substantial reduction in the intensity of the pandemic.
Okay, we have plenty of unanswered questions, but we are nearing the end of our time allotted for the webinar. So as we previously stated, we will follow up with those of you whose questions we have not been able to get to today. We'll follow up with you. We have your contact information from your registration. And we'd like to thank you all for joining us for the update today. If you have questions, additional questions about policy and legislation, please feel free to email policy@aasm.org. If you have coding and reimbursement questions, most likely specifically related to telehealth, feel free to email coding@aasm.org. As a final reminder, the webinar was recorded and will be accessible online in the AASM store. And a link to the webinar, a copy of the slides, the handout, and some additional links that we think will be helpful resources will all be sent to participants within the next day or two. While we realize this was a lot of information, we hope it was helpful. So thank you again and have a great day.